name's Deborah Wilford. I'm an advanced podiatrist in high-risk care. My time is split between community and the hospital, so I actually undertake tier 3 clinics or hot foot clinics in community, and when I work up here at the hospital I work on the wards and at the diabetic foot clinic in outpatients. So mine actually stems from a personal experience for myself when I was younger. I used to be a dancer and I did poly tap, modern and jazz, but I also did karate, and they kind of don't go together. So I ended up with frequent injuries to both feet. So I actually ended up seeing our podiatric surgeon at the time, but there was no intervention because it wasn't warranted. But then I took a particular interest in that and the biomechanical aspect of podiatry. I went on to do my Masters in Theory of Podiatric Surgery, and I actually completed 6 years out of 10 years to become a podiatric surgeon. But then I ended up changing direction because I worked in America, and it just changed my perspective on everything. And when I came back here, for me, I'm very focused around education. So whether it's self-development, educating staff or educating patients, I went on to do a PGCE, and then when I brought that back to the trust, I delivered staff training to district nurses, practice nurses around diabetes and how it affects your feet and the lower limb and what to look out for and how to refer appropriately. For me, it's got to be patient interaction and staff interaction. We have a lot of complex patients with numerous comorbidities, and sometimes, unfortunately, when we see them, especially here on the wards or at the diabetic foot clinic, the disease process is quite advanced. So we're seeing patients with osteomyelitis, a bone infection, and gangrene. Some of the patients we will never be able to achieve that healing because of their other comorbidities, but when we do have that patient that does heal, it's great satisfaction. And also working with other staff, other advanced podiatrists, other members from the other teams like the consultants, just to learn from them. So being with the consultants on the ward or on the clinic, it's just picking up things that they would notice on an MRI scan that I probably wouldn't know because I'm not able to read an MRI scan, but you learn that knowledge so you can then apply it practically. For me, I feel we're autonomous practitioners. So as part of our role, we're able to assess, diagnose and treat accordingly and change our treatment plan based on what the patient needs and what the patients require. Yes, so I've been involved with the service development initially when I came into the role, and then since coming back with the team as well. So we've actually implemented the tier 3 clinic, but we refer to it as the T3 clinic, which the commissioners refer to as a hot foot clinic. So what we're actually doing as an advanced podiatrist is capturing these patients in community and trying to prevent their need to come up here to see the consultant in the outpatient clinics. So I have a patient, for example, where I saw them, my colleague escalated them to my clinic. I did all the appropriate things, put into place the appropriate antibiotic therapy, offloading, dressing regime, referred to vascular, but I also referred them to the diabetic foot clinic because at that time when I first saw the patient, I didn't think we were going to be able to save the toe, and I thought that ultimately the patient was going to have an amputation. Actually, the patient came up to the clinic the other week and the ulcer's healed. So with regards to the integrated care aspect, for me, from my experience and what I've done and what I've got a passion for is the education and training. And so I know that there's lots of pockets of education that happen. So they have the clinical improvement team to provide training for community-based staff. They have a different training programme for the hospital-based staff. And there's not always that crossover. Now for myself, I have delivered on a few of the actual training programs for the hospital, the acute and community basically. So to be able to get an integrated education and training program together for patients and staff, so you've got that engagement from everybody involved in the care of that person, that patient. Obviously, you've got to look into the time factors. So it wouldn't be possible for me to deliver training across Blackpool, Fylde and Wyre because it's too big.